Jeannie, it would be almost impossible for us to have a conversation about risk and not talk a little bit about patients who leave against advice, AMA patients. Bob Bitterman had written an article several years ago after some analysis of claims showing that patients who leave against advice are 10 times more likely to file a lawsuit, not just issue a complaint, but file a lawsuit than those populations of patients who don't leave that way. It's also important to highlight that when we refer to that group of patients we term AMA, that it's not just those people who have refused to do what we say, but it's also those people who've refused any element of the care we recommend, and that means serial testing for chest pain patients, or even parents refusing to allow lumbar puncture for their febrile infant.
Those are some really good points, Ed. And AMA is a real concern for risk managers as well as ED physicians. Can you tell us some of the steps Epic has taken to mitigate that risk?
Our approach with our policyholders is really to be sure that they understand what some of the trends are, but also have a strategy, a process that they can fall back on and approach patients who are in this category in a very disciplined way. The approach we recommend, and we hear this from clients all the time, that when they see a patient who has refused to do what they say, their emotional response is, well, then the heck with you. Get out of here. And I know that at times that's been my own response. I've spent time talking to somebody, I've tried to educate them, and they simply don't want to do what I have recommended. They, as a result, have chosen their own path, and that's their right. I can't force them to do anything, but I have, because of the doctor-patient relationship, some obligations. Our responsibility is to make certain that they understand the sequence of events that has led to the recommendations, the potential consequences of not taking those recommendations, and you have to be very specific about those things. And then you have to document everything. The documentation has to be complete and thorough. What care did you advise them to receive? What are the risks involved in refusing to do what you have recommended? And you know, it oftentimes seems like, well, you're just trying to frighten me, doctor. Well, no, it's not. It's that if, in fact, in the list of things that could happen is you could be paralyzed, I need to tell you that. We also have to talk about what alternatives there are for the care. We all know that there's more than one way to solve any clinical problem, and we have to be sure that they understand alternate models, if in fact we can do that safely. We have to document what prescriptions were indicated and be very specific about plans for follow-up care. The evidence also has to be recorded of the patient's ability to understand what the options are. We deal with patients who are inebriated, intoxicated with any number of substances, and then those who with diminishing capacity due to aging or some neurologic condition. We have to identify that and make sure that they or a family member or some responsible party is able to understand and help participate in the decision to choose a path that's different than what we recommended. I know that one of the things I have really become accustomed to doing is telling patients that even though you're leaving and you're not going to follow the recommendations that I think are important for you, I think that you should understand we're not going to lock the door behind you. If you change your mind, if you can get the babysitter for your child and come back for that pelvic ultrasound, if you can, or if you begin to experience a worsening of your symptoms, come back. We're not going to hold this against you. And I need to document that conversation so that they're aware that the door is always open for them. Jeannie, honestly, I'd like to hear what your observations are about the documentation piece. I know you're out there in departments for our clients and seeing how this issue is addressed. What are your observations?
Certainly from the risk manager's perspective, we agree with everything that you've said, but there are some really important elements that you need to think about when you're thinking about defending yourself against a patient that decides to leave without completing their treatment or refusing a portion of their treatment. And when that happens, the emergency physician needs to be extremely diligent about utilizing the refusal of care process. You never want to be in the position of offering the patient admission, suggesting that the patient has a choice that they can be admitted or that they go home, or negotiating care with the patient without also having a refusal of care. So your primary plan of care is your primary plan of care. If the patient doesn't want to do that, you have them sign the refusal form and then negotiate an alternate plan. It's also critically important that you provide the highest level of care that the patient will accept. And what I mean by that is if we go back to your example of the patient with chest pain that's refusing hospital admission, you might want to offer that they could stay in the ED and have serial testing instead of being admitted to the hospital, and maybe that would be agreeable to them. But again, you want to make sure that the record reflects that your first plan of care was to have the patient admitted, that they refuse that, and as an alternative you're going to do serial testing. I think a simple rule of thumb is to provide the best care possible in light of the patient's refusal. For example, if you think the patient needs admission and IV antibiotics and that's what you've recommended to them, but they can't stay in the hospital for whatever reason and are refusing, wouldn't they be better off going home with oral antibiotics versus none at all? You just want to make sure that the patient is well aware of the associated risk and very specific to the condition that they're being treated for, and that you're advising against the outpatient therapy. At the end of the day, the record should reflect that you gave the patient the best chance for recovery in light of their decision. So in summary, you don't want to let the patient talk you out of your plan. You do want to have them sign a refusal of care form. You do not adjust your plan of care and fail to document the patient's refusal. It's fine to give them an alternate plan of care, but you don't want to do the alternate plan of care and not document that they refused your initial treatment plan. And like you mentioned, you don't want the AMA process to be a source of conflict. And you always need to remember as a physician that a competent patient always has the right to make the decision. You recommend the treatment and they say yes or no. I think the next thing that you can do to protect yourself is do a callback to the patient the next day just to see how they're doing, and once again invite them back to complete their care and make sure that it's documented. Experience has taught us that the best protection from liability when a patient refuses care is through communication and documentation. And we both know that protecting yourself is critical when you're dealing with a patient who's deciding not to follow your best advice on treatment. The other thing to consider is that by working to protect your interest and protect yourself from liability, you also protect the patient as well by ensuring that they do understand all of their options and that they make the decision based on accurate and complete information.